All right, welcome back. Let's get into our next case. This one's actually a lot of fun. We're gonna switch gears a little bit out of the vertical control and move to something that's a little bit common, bimax protrusion. And we're gonna show how we took care of this case in a pretty easy and predictable way. So Mila came to us as a 24-year-old female with a chief concern strictly of protrusion of her teeth. She couldn't close her lips. She didn't like the way that it looked in profile, and she just felt that her teeth were always really far forward. So we went ahead and we treated her in a great way, short period of time, I think. And I really want to kind of get into this so that we can at least give you some options on what happens when we get these patients, because there was also another layer of complexity, which we'll explain in the next slide. So Mila comes in and you can see that she has a little bit of arch constriction in the mid-buccal segments. She's a little bit tapered, some protrusion. The lower is a little bit crowded with the same amount of constriction and some lingually tipped buccal segments. So, we know that we can do some posterior arch development, some arch widening, molar rotation, but that's not going to give us enough arch length to significantly retract these teeth. The other layer that I was talking about is that she also had a request that we treat this non-extraction. Now, this isn't an extraction, non-extraction debate. That's for a different discussion. But we are all facing a lot of social media pressure based off of the non-extraction extraction debate. Because if you're anything like me and you're following social media, there's a lot of conversation out there about airway, tongue, extractions, retraction, all of this good stuff. And, as orthodontists, we know that there's time and a place for it. But, when patients are scrolling and seeing, their perception is something different. And, we have to understand that. So when she came in and said that she wanted to retract her teeth, but she did not want extractions, we came up with a plan that solved that problem. And that's what I want to get into because honestly, it was something that worked beautifully. So if we look at this, pretty non-contributory. She had, a loss of a lower left first molar at some time, which, we know, and we're going to plan for an implant back there. She's got some remaining wisdom teeth in the upper left, lower right, and lower left, but nothing else really too out of the ordinary. Here's where things get a little bit spicy, if you will. Skeletally, she's class 1, right? A and B, SNA, SNB. Her mandibular plane is fine. It's perfectly normal. But her dental component is truly bimax protrusion, right? Her upper one to NA is 13 millimeters. Her angulation is at 118. And even her lower one NB is at 9 and 98. So, when I look at this, I see protruded and proclined upper incisors and protruded lower incisors with fairly decent angulation. This leads to a soft tissue imbalance. Her lips are really forward. Her mentalis is strained. And we all know the rest of this pattern. So we went ahead and it took us about 1.5 years. We used some braces and some TADs. We're going to go through something called the pull procedure. If you've been following anything I've been doing, I've come up with these fun acronyms. The lift procedure was the vertical control TADs, and pull is going to be some AP, which we'll get into. But you can see treated beautifully. Again, everything looks nice. She is missing a lower incisor. So we know that we're going to have either some residual overjet or a difference in buccal occlusion, which is what we're seeing on that right side. But again, treatment time was 18 months, and most of this wasn't complicated because of tooth movements. It just took time to retract in the way that we set up the force system. So here's her pre-treatment records. And again, this is the day we put braces on. We're using the Damon Ultima system, and even though I'm retracting, I'm using retrocline brackets to just help me upright these teeth. Some people ask, well, wouldn't you use procline on this? Because if you're going to arch develop and retract, you have to hold the upper incisors at a certain inclination. My response to that is, if I got to phase 2 and I saw that the teeth were slightly upright, I would just swap the anteriors or even the upper ones with procline brackets at that time. But because I was really targeting uprighting these teeth and they were so proclined and protruded, I just figured that I wanted to use all that I could get. So retrocline brackets on the upper and lower, and here's what we did. So the pull protocol is something that I've kind of coined, and again, this comes from Dr. John Lynn. He calls it the MB1 or MB2 infrazygomatic TAD protocol. I just like these 4-letter acronyms. PULL stands for posterior upper lip line reduction, because I'm using this TAD strictly to reduce the soft tissue profile. When I look at extractions, I'm not necessarily extracting because there's too much crowding. I'm not extracting because the teeth are proclined. I can use TADs to resolve some of that. I'm using this specifically so that I can retract the upper and lower teeth and reduce the lip protrusion. So posterior upper lip line reduction is kind of fun. So here's how it starts. We're going to place two 12 millimeter OBS TADs. Okay, I use the ortho bone screw that Chris Cheng developed versus the vectors, and the reason why is because I just really like the sharpness and the shape of the OBS system for things outside of dental alveolar bone. So if I'm looking at zygomatic TADs or buccal shelf TADs, I typically default to the OBS TAD system. So the way these go in is we begin at 90 degrees right around the mucogingival line, and what happens is as we get primary insertion of the cortical plate, you slowly start to turn and angulate at the same time. This is the best that I can do, but you can see that they kind of go in, and as we insert, according to Dr. John Lin, you need about 4 millimeters of insertion into the cortex, and you're going to see some threads that come out through the gingival margin. That's why they are 12 millimeters. It does have a longer collar, but at the same time, most of the time I'm going to see some of these threads. This is what it looks like from the buccal. And what ends up happening is we want to activate the TAD with about 250 grams of force to the wire itself. And we really go around the hook. Now, what I'm not showing here is typically what I'll do is I'll start with a piece of C-chain from the TAD. I'll wrap it around the hook, but I won't engage the hook with the eyelet. I wrap it around so that I get kind of a double stretch. So it's one piece forward, one piece back. That gives me about the 250 grams that I need and gives me a really nice modulus of elasticity. So I do that on both sides. But remember, there's a little bit of a force system at play. You're trying to distalize the upper arch, and we're using this force system. What ends up happening is that you get a moment and a force that you probably wouldn't expect. And that's that the upper maxilla rotates clockwise around its center of rotation, which is somewhere around the bicuspid region. And if you're not careful, what happens when you're distalizing the upper arch is you can get this canting of the occlusal plane. Now, in many cases it's good, but in a case like this, we don't want it to lead to a gummy smile. So in the literature, they report placing an anterior TAD right at the midline. I do it a little bit differently, which we'll look at in the next few slides. So you can see the pull TADs in place. Again, it's just two simple 12 millimeter OBS TADs placed right into the infrazygomatic arch. They're pretty easy to place. It doesn't have a lot of patient morbidity, and they're just really helpful. So you can see how this is activated, and then basically the patient just comes in. We switch wires as we're going through phase 1, phase 2, phase 3, and we activate TADs. This is what it looks like in 6 months. And you can already see that we're getting some uprighting, but most of that uprighting is probably due to arch development, and I'm fine with that because as you start to retract, it just takes time to distalize this upper arch. So you can see that we started with an 014, placed the TADs, placed an 018, 140275, and basically started class 3 elastics. Because remember, this is a bimax protrusion case. The upper arch and the lower arch both have to retract. So we're using the TADs to retract the upper teeth, and then I'm using the class 3 elastics to retract the lower teeth. Some people ask if I run the class 3s off of the TADs. I don't. I keep it simple. I just use a light class 3 elastic off of the molar, and then I know that I'm overpowering the molar force with the TAD retraction. So it seems to work just quite nicely. So here she is at the end of phase 1, and you can see that things are looking good. Now is when we went ahead and placed our anterior TADs because I started seeing that her anterior teeth were erupting. They were just getting a little bit gummy. So I went ahead and placed 2 vector TADs between the canine and the lateral, which is what we do for our vertical cases or gummy smiles. And then every time she came in, I just tied the pull TADs with 250 grams of force and the anterior TADs with 60 grams of force, which is the normal protocol that we've been talking about. So this looks complicated, but it's really not. Right? If you just think of it from a force management standpoint, this system is set up really, really ideally. And really all we're doing is we're managing the teeth with our braces, and we're managing the skeletal with, or the dental component of her protrusion with the TADs themselves. So now it's basically going through the wires, and every time she comes in, we keep activating the TADs. Phase 2 usually lasts 3 months. we went ahead and repositioned a couple brackets when we placed the anterior TADs and went to 180275 copper nine ties, which is our full expression. From here, we went ahead and put in our final wires, which are 180275 steel over 160275 steel, and began just retracting. So once I got the upper level set where I liked it, and I think I probably intruded a little bit much, which is okay because by retracting, we're going to get a little bit of eruption. After I did a little bit of a gingival procedure, you can see that her smile arc looks good, but I think that we don't want to intrude these anymore. But again, 4 months later of retracting, it balances out because the clockwise rotation of the maxilla erupts those teeth a little bit more and puts me right back where I want. This is basically a week before debond. And now we can go ahead and look at how much was significantly done in those 4 months. So you can see that phase 3 lasted a little bit longer, but that was just because we wanted more effect on the retraction. When she came in, it was simple. I didn't even have to remove the wire. All we did was retie the TADs, make sure that she looks good, and just ask her how she was doing. And these TADs were secure, stable the entire time. So a week later, you can see that we removed them. Again, the occlusion on the right side is a little bit off, and the center midline looks pretty good. Again, there are some things that I could pick apart in this now, but that's for a different lecture. But again, I wish I would have probably added a little bit more torque to that upper right lateral. But again, when you're doing these complicated movements, sometimes you get lost in some of the very small details, which again, it happens to all of us. And just know that we're always trying to be perfect, but we fall short many times. But you can see just from a facial standpoint how this looks. Now let's look at the dental component, okay? What's fascinating about this case is that it doesn't look like we did that much, right? Yeah, we've got some arch development, and the overbite looks about the same. From here, we can look like we uprighted the teeth slightly, and the occlusion looks functional. We created space on that lower left for the molar, and we were able to level the lower plane of occlusion and get a really nice functional occlusion. We were able to develop the upper arch, but all in all, it doesn't look like we really accomplished a lot for the force system that we set up. But just wait. When we really look at this case and we analyze the post-treatment records, again, nothing too out of the ordinary with the X-ray here, but look at this. This is the after stuff. And if you compare these numbers, we obviously didn't affect anything skeletally because we weren't trying. The upper one to NA was at 13 millimeters. We brought it down to 7. I mean, just think about that. We were able to retract the upper incisors essentially 6 millimeters upper one to NA, and we were able to maintain the 105-degree angle very, very nicely. When we look at lower one to NB, we've got 9 millimeters to 5. So we're able to bring that back to a fairly normal range. So when we look at the soft tissue now, we can see that instead of 3 millimeters and 7 millimeters, we're at 0 and 2. This is, for all accounts, a surgical or an extraction-based result. And, I think that the simplicity of what we're doing and the conservativeness that I would say compared to removing 4 teeth is something that we all should probably appreciate and understand that it's not difficult to do this. You just have to go a little bit outside your comfort zone. If we go ahead and we look at the actual progression, this is where it gets fun. You can see through this, we got more and more lip retraction. And at the end, this is, to me, beautiful, right? If you look on the left, protrusion, mentalis strain, lip eversion, just everything was straining. In a 24-year-old patient, this would be really difficult for her to maintain her whole life. If we go ahead and we look at this in lateral profile, you can just see how natural her lips look. Even her subnasal area looks so much better because she's not so protruded. If we look at this, look at the macro aesthetics, the mini aesthetics, and the micro aesthetics, this is something that just is just a really fun case to show. So 18 months, I think that we solved most of the problems. She was elated and happy that we're able to resolve her chief concern, have such a dramatic improvement, and also not extract teeth. So if you like this case and you find it valuable, please forward it to your friends. Make sure that you subscribe. Again, we've got YouTube, Instagram, all of it helps. Believe me, we don't charge for this stuff right now. So it's really, really important that we spread this information, because when I was a young orthodontist or an orthodontist learning to do this, I didn't have these tools that we have now. So, it's kind of our mission to give this back. So hopefully you enjoy, and stay tuned for the next case. Bye-bye.